Thank you very much, Ken. In order to make a bridge between Dr. Anderson's talk, Dr. Mikkel talk, and the final part, which is Dr. Berenson's case presentations and discussions, I was asked to discuss something about first-line treatment in myeloma patients, particularly focusing in smoldering and active myeloma. You see my disclosures. And to start this, what I would like to do instead is giving you a summary of what has happened this morning in discussing first-line therapy and putting the emphasis on smoldering on first line. Unfortunately, I cannot talk about the Yankees nor the Mets because it's a sad story, but maybe we have hope. The hope exists already for multiple myeloma anyway. This is a slide that depicts exactly the heterogeneity of multiple myeloma. I'm always trying to use it because it's a slide from the 70s, and since then we knew that already there was a heterogeneous population of cells which are involved in this disease. We don't need the molecular proof that indeed myeloma has an heterogeneity upon presentation with the normal-looking plasma cells in one side coexisting with the plasmablastic and abnormal plasma cells in the other side. Through this new genome sequencing, we have already learned that we cannot target only one single gene, and the challenge of this disease, just paraphrasing what Dr. Anderson just said, it is extremely difficult to identify one particular aspect to deal with this disease in general. Not only upon presentation is a problem with multiple myeloma, with its heterogeneity, but the heterogeneity occurs upon exposure with treatment. And as you can see from this review and others, such as Dr. Garrett, who present today, there is a heterogeneity as the disease relapses with new changes, genomic changes as the cell goes on. So I would propose to you that if the initial population of cells are more homogeneous upon presentation at the precursor stage, either by MGOS or smoldering, perhaps that would be the best place to initiate therapy. Would not allow to that heterogeneity of other clones or subclones to appear and cause the CRAB manifestations. So the first approach is to try to do more chemoprevention and try to just focus on those precursor disorders such as MGOS and smoldering. And perhaps the best model to deal with that frontline treatment would be the smoldering disease. Perhaps because the smoldering disease is the one that has a higher level of progression. You can see here in the model, either by the Mayo or also in the similar model by the Spain group, in which the larger amount of progression exists in the first 5 years. And I would propose to you that those 5 years identify patients in what we call myeloma in evolution rather than calling smoldering. Anything that happens after those 5 years are those with real smoldering patients and those who have the lower risk. So perhaps trying to focus on that population, on those patients who are actually progressing on the first 3 to 5 years, are the ones that we're going to be more successful in the chemoprevention. Of course, Dr. Comenzo already discussed this in large amount. Perhaps the most successful intervention was reported by Dr. Mariví Mateos in the New England Journal of Medicine, in which they treated lenalidomide and dexamethasone in this trial, looking at time to progression and overall survival as secondary objective. And as you can see, there was an induction phase with lenalidomide and dexamethasone at more intense dosing with a maintenance lenalidomide in the treatment arm, whereas the control arm was just therapeutic abstention. And not to repeat what already has been said, it has been shown that time to progression was inferior in those patients who were just observed, and it was superior in those patients receiving lenalidomide and dexamethasone, and that more importantly, in that chemoprevention or sort of chemoprevention trial, the overall survival was also significantly elevated in those patients who received actually lenalidomide and dexamethasone. So that bears the question is, are we selecting properly the patients for chemoprevention? And Dr. Comenzo already mentioned what Dr. Langdon also insinuated, is that we're not identifying properly the patients as smoldering by just doing skeletal survey, and I think that was one of the weaknesses of this trial, in that they just did skeletal survey and then they just follow the patients upon symptoms to follow up on skeletal for progression. Anyway, as you already know, there are other trials going. The most salient, perhaps the most interesting, would be the ilotuzumab trial and the CRD trial that Dr. Langdon already mentioned. So once the disease is already advanced, we have two approaches. Everybody follows similar approaches for the younger patients, induction, transplant, consolidation, and maintenance, whereas for the older patient, the regimens are more gray. The concept is similar of induction followed by consolidation and maintenance, but that's in general the strategy for treatment. In that regimen, in that sequential regimen, perhaps what we aiming to is achieving complete response as the first surrogate marker for overall survival. And that has been noticed both in the relapse setting and in the frontline. This is, in this slide, you can see work that we did out of the bortezomib and versus dexamethasone APEX trial, in which we demonstrate that the deeper the response, the better is the outcome. Similar in the transplant setting, Dr. Vandervelde has done an exhaustive evaluation about the value of complete responses. And in general, after evaluating almost 5,000 patients with transplant, the majority of the patients do have improvement in outcomes, even utilizing CR, NCR, and VGPR post-transplant. Moving in more modern data, we have data from the French experience with single transplant or with double transplant, in that indeed achieving a more profound response, either CR or VGPR, you will get better outcomes in terms of progression-free, event-free, and overall survival. From the other point of view, from the older group of patients, a retrospective analysis done by Dr. Gay, utilizing data from VISTA and Dr. Palumbo's trial, you can see that even in the elderly patients, achieving a profound response will offer better progression-free survival and overall survival. And again, going back to a more stringent evaluation of complete responses, this by the Spanish group, you can see that in those patients who are older than 65, achieving more than a stringent response by immunophenotypic complete response, perhaps utilizing the more sophisticated flow cytometry methods, we can achieve better progression-free survival with deeper responses. So I guess we have good evidence that better outcomes result from better tumor mass results, tumor mass reduction. From this paper, from prior to the use of novel agents, we have, the Spanish group has reported that more than 10-year CRs can be maintained and probably maintain post-transplant, even without the use of the novel agents, suggesting that indeed potentially there is a cure in those group of patients. Dr. Barlogi also mentioned this morning about the value of sequential therapy, achieving persistent long-term remissions as a potential eventual initiation of the idea of a cure. So utilizing either better drugs or better sequential therapy with better strategies, I think we have all gotten to the point in which we can achieve deeper CRs, deeper VGPRs, and the important will be to maintain those complete responses for long term. In our experience with utilizing the BIRD regimen, which is clarithromycin, lenalidomide, and dexamethasone, we have been able to achieve similar response rates with a CR rate of 41%, a VGPR of 36%, and SCR, strict complete responses of 79% in those patients with CR. As one of the initial contributions of this trial is that just by combining those two agents, lenalidomide and dexamethasone, and just adding the clarithromycin, we can achieve similar deep responses to the compared with the most expensive or aggressive regimens, including double transplantation. And although we cannot compare outside of a randomized trial, the other contributions that we were able to provide with this regimen is that continuing the lenalidomide can accrue deeper responses, and this was the overture of the concept that we are all using of maintenance. Perhaps the first contribution before maintenance was ever considered was the data emanating from this trial, that the longer you expose your patient to chronic lenalidomide, you can achieve better responses and deeper responses. Recently, Dr. Rossi has published an update of this experience, and we have achieved a median of progression-free survival of 70.8 months with a 5-year progression-free survival of more than 50%, with an overall survival that exceeds 80% at 4 years, with a median that has not been reached. And this is a follow-up that now reaches almost 7 years. So you can even suggest that there's a certain group of patients that may achieve this type of good outcomes, long-term outcomes, without having to go through the aggressive regimens defined before. We were asked to compare those patients who received the BIRD regimen and constantly versus those who actually got transplant after the induction of the BIRD, and we would see that, in fact, the patients remain in the same outcome, regardless whether they were transplanted or not. You would have expected that patients who would not got transplanted were those who were the aging, the patients with comorbidities, and yet, because we did not use lenalidomide maintenance post-transplant, I think that the curves look exactly the same, indicating that maybe the transplant is another way of achieving long-term results that can also be achieved by using chronic lenalidomide. We also had the ability to look at minimal residual disease from the molecular standpoint in those patients who achieve a complete response long-term in the BIRD. And as you can see, patients 15, patient 40, the band that was initially identified by patient-specific signal, it disappears once they have achieved a CR. So for those who could propose that the transplant CR is not the same as a lenalidomide-based CR, you could use this data to argue that perhaps even the use of lenalidomide long-term can achieve that type of molecular responses. And we have the ability to follow these patients long-term and see if the relapse occurs before or after, depending on the presence of the molecular signal or not. So these are just other regimens that can achieve similar results. We have the Mayo Clinic Cyborg giving more than a VGPR of 60% with a CR of 39%. You have, of course, the BIRD giving CR of 40%, almost 40% with a more than a VGPR of 73%, and the VRD from the Dana-Farber showing 100% overall response rate, but also more than a VGPR of 74%. And I don't think that we will ever know what's the difference between these agents, these combinations, because prospective trials to answer that question cannot be done. Suffice to say, however, that now the presence of carfilzomib in combination with lenalidomide and dexamethasone can give even better results than those three regimens that I mentioned. And perhaps a lot has to do with the chronicity of the treatment, because Dr. Jakubowiak gave the lenalidomide for more than 9 cycles and continued the lenalidomide even after suspending the carfilzomib, and achieved a VGPR of more than 62% with a CR of 42%. So I think the field is moving towards achieving higher levels. One of the concepts that we should take away from this review is that we should reject any induction regimen that does not achieve a CR rate of more than 30%. Any regimen that does not achieve that, it would be suboptimal in my point of view, and that as we move forward, we would like to do, or the trial that we are now running is a multi-step trial, a sequential trial. Dr. Tomermark designed this trial and is moving it forward, in which carfilzomib and dexamethasone is given at escalating doses until achieve maximum response, and then we will switch to lenalidomide-based therapy, particularly the BIRD, which in turn, and when proper trial is completed, can be switched to pomalidomide, and then eventually evaluate minimal residual disease at the time of stem cell collection and at the time of achieving complete responses. So I think I could try to convince you today that CR should be the goal, but that we should maintain it with strategies of long-term therapy, keeping the pressure on those clones that can eventually progress, and that we need improvement in improving those numbers with better regimens, consolidation post-transplant, and start talking about other strategies, perhaps allogeneic transplant in certain populations. Thank you very much for your attention. These are my collaborators.